कि आपने हमारे में 30-40 बीमारियों का हमने ना बनाया हुआ पेशेंट इन्फॉर्मेशन बुकलेट्स हिंदी एंड इंग्लिश में, इंक्लूडिंग डीएमडी, एसएमए एंड अदर्स, मेनी अदर्स. तो वो हम पेरेंट्स को दे देते हैं, हमारी पेडियाट्रिक न्यूरोलॉजी नर्स दे देती है, विच दे कैन गो एंड रीड, एंड वी हैव सम वीडियोस एंड ऑल. तो वो दे सी, तो वी हैव गिवन अ मटेरियल कि वो कितना, क्योंकि पहले में बिल्कुल आप सही कह रहे हो कि 3 पॉइंट से ज्यादा नहीं बताओ, क्योंकि उनको इम्बाइब कितना होगा. तो वी गिव देम मटेरियल, तो मटेरियल कैन बी एडेड. बट व्हाट आई वांट टू आस्क डॉक्टर मधुलिका मैम कि the dilemma of how to handle this genetics one. That, you know, because when you know X-linked and you know repercussions which can be there even in many educated families. तो मतलब how to break that, that will be coming in the subsequential interview. पहले में तो आएगा नहीं, है ना? तो मैं वो कैसे करना है मतलब?
That is tough.
तो ये शिफाली बहुत इम्पोर्टेंट बात है, पर्टिकुलरली हमारे कंट्री में, क्योंकि सब चीज के लिए फीमेल्स को ही ब्लेम करते हैं. हस्बैंड वाइफ, उसमें भी अल्टीमेटली ये कहते हैं कि ये तो वाइफ की वजह से ही हुआ है. तो यूजुअली जब हम जेनेटिक्स के बारे में बताते हैं तो हम ये नहीं बोलते कि कौन कैरियर है, हम यूजुअली ये नहीं बताते हैं. हम जो बताते हैं वो ये है कि ये बीमारी लड़कों में होती है आमतौर में, और अधिकतर केसेस में लड़कियों में नहीं होती है, और अगले प्रेगनेंसी में इतना रिस्क है बीमारी होने का और उसके लिए टेस्ट किया जा सकता है. पर डिस्पाइट दैट, मतलब हम उनको ये इन्फॉर्मेशन देते हैं कि बीमारी के बारे में और रिस्क अगले प्रेगनेंसी के बारे में और टेस्ट के बारे में. पर हैविंग सेड दैट, क्योंकि बहुत सारी जानकारी ऑलरेडी लेकर आए होते हैं, ऐसा भी हो सकता है कि फैमिली हिस्ट्री इस तरह की हो ऑलरेडी कि मदर की साइड में और भी अफेक्टेड लोग हों और उनको आइडिया भी हो कि मदर कैरियर हो सकती है. तो उसको हमें एक्सप्लेन करने के लिए, क्योंकि 2/3 केसेस में कैरियर होगी मदर, 1/3 में ये सिर्फ बेबी में ही प्रॉब्लम आई है, तो उसको एक्सप्लेन करने के लिए हमें ये बोलना पड़ेगा कि कैरियर स्टेटस इज नॉर्मल एंड वी हैव टू टेल द फैमिली, इवन द फादर, एनीबडी वुड बी अ कैरियर ऑफ 8 to 10 एबनॉर्मल जीन्स, और उससे कोई नॉर्मल हेल्थ पर फर्क नहीं पड़ता है. दैट इज जस्ट बाय नेचर कि वो कैरियर है, एंड देयर इज नो वे टू फाइंड आउट अनलेस कि आप प्री प्रेगनेंसी सबका ही टेस्ट कर लो कि कौन कैरियर है. कोई बता नहीं सकता है कि इस फैमिली में डीएमडी होने वाला है जब तक कि कोई फैमिली हिस्ट्री नहीं हो क्लियरली. तो कैरियर स्टेटस को स्टिग्मेटाइज ना होने दें, ये हम लोग पूरी कोशिश करते हैं, और उनको हल बताने की ज्यादा कोशिश करते हैं कि चलिए अब ये है फैमिली में, अब आगे क्या किया जा सकता है प्रिवेंट करने के लिए. पर यू आर वेरी राइट इन सेइंग दैट देयर हैव बीन फैमिली डिस्प्यूट्स. पर इसके लिए मैं यही कह सकती हूँ कि द फैमिली मेंबर्स एंड द हस्बैंड्स पर्टिकुलरली हैव टू बी मोर एजुकेटेड, और उनको क्लियरली हमें बताना पड़ेगा कि कैरियर स्टेटस को हमें ब्लेम गेम करके नहीं करना चाहिए कि इनकी वजह से बीमारी आ रही है. तो ये डिफिकल्ट सिचुएशन बहुत बार हो जाती है. बट having said that, there are few families जिनको पता है, मतलब they come with the idea कि हमें पता है इधर से आ रहा है, and still they are very supportive. तो ऐसा नहीं है कि सारी फैमिलीज में ही ऐसा होता है. आई थिंक मुझे लगता है थोड़ा अच्छा एजुकेशन से और थोड़ा एक्सप्लेन करने से कि कैरियर स्टेटस नॉर्मल है, किसी में भी हो सकता है, थिंग्स आर बेटर. बट वी हैव टू हैंडल विद केयर, एंड एट टाइम्स हम कोशिश करते हैं कि वो हम थोड़ा असेसमेंट हमें आ जाता है विद टाइम कि किस तरफ प्रॉब्लम ज्यादा है, कि हमें पूरा क्लियरली कैरियर स्टेटस के बारे में हमें कितना डिटेल में जाना है. तो ये एक इम्पोर्टेंट हमें पॉइंट ध्यान में रखना पड़ता है कि हम कितना डिटेल में जाएं, पर्टिकुलरली इन द फर्स्ट, नॉट इन द फर्स्ट, यूजुअली सेकंड, थर्ड, और व्हेन दे आर प्लानिंग प्रेगनेंसी. दे वुड कम टू अस व्हेन दे आर प्लानिंग प्रेगनेंसी, और इवन इन अर्ली प्रेगनेंसी दे कैन कम टू अस. थैंक यू
मैम. ये प्रोफेशनल्स और पेरेंट्स, अगर पेरेंट्स को पता है एक्स-लिंक्ड है, तो हाउ टू बी काउंसल the joint family कि the blame is not put and
उसके लिए वो ये शिफाली जो मैंने अभी बोला ना कि ये क्लियरली बताना पड़ेगा कि कैरियर होना बीमारी नहीं है, और कोई तरीका, जब फैमिली हिस्ट्री थी अगर वो पहले आए हैं तो हम सॉर्ट आउट पहले कर सकते थे, पर अगर पर्टिकुलरली फैमिली हिस्ट्री नहीं है तो कोई तरीका नहीं था मदर को पता होने का कि वो कैरियर है, अनलेस कि हम प्रेगनेंसी से पहले ही टेस्ट करते जो रूटीनली नहीं करा जाता है. तो उनको यही एक्सप्लेन करना पड़ेगा, और आई थिंक मोर पॉजिटिव साइड ऑफ दैट वी हैव टू टेल देम कि ये प्रेगनेंसी में हो गया है, पर नेक्स्ट प्रेगनेंसी में टोटली प्रिवेंटेबल है, ये हम इसको हेल्प कर सकते हैं. तो most families will understand, some families will still not understand. तो वो उनका perception कुछ इस तरह का बन जाता है, and it becomes difficult And as you are said that there are, as I am telling you, not for X-linked only, there have been family disputes even for recessive disorders. I have seen like disorders like thalassemia, cystic fibrosis, जबकि दोनों पेरेंट्स कैरियर हैं, बिल्कुल क्लियर है, फिर भी they will have dispute कि नहीं ये तो वाइफ की तरफ से आया है. तो ये this will need more education, I think, Shefali, at all levels, family levels. और जब भी group meetings करते हैं parents की, I think this message has to go to them to convey this message very clearly. I think that would help.
मैम ब्लेम इंक्रीजेस जब मैटरनल अंकल वगैरह की हिस्ट्री होती है,
हाँ वही, अगर फैमिली हिस्ट्री है तो फिर हाँ
Yeah.
फिर तो उनको पता रहता है, पर उसमें भी हमें एक्सप्लेन करना पड़ेगा कि शुरू में आइडेंटिफाई नहीं, मतलब अगर हम ये भी कहने लगते हैं कि ये आपको शुरू में आना चाहिए था, आप लोग लेट आए हो, दैट आल्सो दे मेक्स them very guilty. So I think we should start from where we are as of now. जो हम पहले कर सकते थे उसको तो हम रिवर्ट नहीं कर सकते, तो अब हम कैसे आगे अच्छा कर सकते हैं उस पे फोकस अगर करेंगे और पॉजिटिव्स बताएंगे तो आई थिंक मोस्ट फैमिलीज वुड अंडरस्टैंड.
Thank you. Thank you, ma'am. Can we have the next question? Yeah. Next question, हम वो ट्रांजिशनल केयर के बारे में बात कर रहे थे. Next, fifth. तो बेसिकली बहुत इंपॉर्टेंट है कि हम प्रॉपर एक प्रोटोकॉलाइज्ड वे में करें. सर इसमें तो प्रोटोकॉल करना चाहिए ना, बिकॉज वी हैव टू. Yeah, I mean, because the point is, it doesn't happen one day. They have to be primed. They have to be primed, नहीं? Because because I example बताऊं सर, एक 42-year-old है, वो अभी भी अपनी वाइफ को लेके मेरे पास आ जाता है एपिलेप्सी में, जबकि मैंने उनको फॉर्मली डॉक्टर मंजरी को दिया हुआ है. आप समझ रहे हैं, क्योंकि वो उसको लगता है कि वो उसको ट्यूबरस स्क्लेरोसिस है मैम, और वो मतलब 25 ईयर्स से दिखा रहे हैं ना, तो फिर उनको लगता है कि नहीं, वो इमोशनल अटैचमेंट होती है, फिर भी आ जाता है उनका कार्ड दिखाने. तो मतलब हाउ टू इंश्योर कि दे आर नॉट लॉस्ट सर, बिकॉज मेनी टाइम्स क्या होता है, जो एडोलेसेंट्स होते हैं, पीडियाट्रिक भी देख रहे हैं, एडोलेसेंट्स थोड़े दोनों साइड में मिक्स हो जाते हैं. तो सर व्हाट डू यू गाइड हाउ टू गो अहेड विद द ट्रांजिशन? अब जैसे SMA के टाइप 3 हैं, वो 16 साल के हैं, तो उसकी फॉलो अप के लिए क्या है, एंड वेदर प्रोटोकॉल करना चाहिए कि नहीं, वेदर ग्रेडेड में करना चाहिए, हाउ एग्जैक्टली डू यू वांट टू गाइड यू बीइंग एन एडल्ट न्यूरोलॉजिस्ट, हाउ डू एडल्ट न्यूरोलॉजिस्ट यू अंडरस्टैंड कि मतलब हमारी साइड हम समझ रहे हैं, आपकी साइड आप ही बता सकते हो कि कहाँ पे कमी हमारी तरफ से है एंड कहाँ पे क्या, यू नो, दैट इज व्हाई आई एम रिक्वेस्टिंग यू.
ओके, सो एक बात तो ये, हम ये बात क्यों कर रहे हैं, ट्रांजिशन की क्यों बात कर रहे हैं? क्योंकि बच्चे बड़े होते हैं, पेरेंट्स बूढ़े हो जाते हैं, बीमारी बढ़ती है, कॉम्प्लिकेशंस आते हैं, ट्रीटमेंट्स बदल रहे हैं. तो वही जो बच्चा जिसको जो 10-15 की उम्र में एक बीमारी थी, 30-40 के आगे डायबिटीज होता है, ब्लड प्रेशर होता है, सोशल नीड्स बदलते हैं, साइकोलॉजिकल इश्यूज बदलते जाते हैं. लेकिन सबसे बड़ी चीज ये रहती, समस्या ये रहती, कौन सी मेडिकल स्पेशलिटी उनको संभालेगी. एंड क्योंकि ये बीमारियां चलती ही जाती हैं तो निधन भी होता है. एक चीज बहुत फर्क है पीडियाट्रिक्स और एडल्ट केयर में. पीडियाट्रिक्स में बच्चे के साथ एडल्ट्स रहते हैं, पेरेंट्स, प्रोफेशनल्स, और हमारे को ट्रांजिशन ऐसे स्टेज पर करना है जब पेशेंट खुद इंडिपेंडेंट एडल्ट बनता है. और पेशेंट जब इंडिपेंडेंट एडल्ट बनता है तो नोबडी सेज कि आई मीन ठीक है, आई मीन अभी भी वी सी mothers and fathers coming around at 40 and 50 with their children, but otherwise it is understood कि मेरे पास तो पेशेंट खुद आएगा. So this protocol, ये जो ट्रांजिशन का जो प्रोटोकॉल है, actually it has to start when the child begins to understand all of this. So when do we start? Ideally it has to start at the age of 13 and gradually बच्चे को समझाया जाता है कि आप अभी खुद की जिम्मेदारी लोगे. तो goals are, the youth has to understand his or her chronic illness and start taking responsibility for its management. Of course, हर एक पेशेंट एक बराबर नहीं रहता, सबकी उतनी कॉग्निटिव कैपेसिटी नहीं रहती, तो जितना होगा उतना. फिर केयर गिवर्स को, पेरेंट्स को, उनको भी ये समझाना पड़ता है कि they have to start accepting the patient as an adult. एक मिनट, हाँ मुझे मेरा फोन बंद करना पड़ेगा, नहीं तो there's somebody who's trying to get through to me. Just give me a minute. Yeah. So then probably the most important thing, and this is something that I'm sorry I have to find fault with my pediatrics colleagues, कि appropriate adult provider कौन है, वो decision probably 18 के पहले हो जाना चाहिए, probably 15-16 में ये शुरू हो जाना चाहिए। और आप लोग तो सिस्टम में हो, तो इसलिए आपके पास you have the ability to transition. हमारे यहाँ तो we are all independent private care में, so how does this happen? I think that is somewhere that maybe the Pediatrics Association in abroad it is considered an essential responsibility, so we have to do this. और ये provider जो भी adult provider है उसका communication बराबर हो जाना चाहिए। अब मैं जब देखता हूँ कि ऐसे पेशेंट जब हमारे पास पहुंचते हैं या एडल्ट होते हैं तो कौन कौन इन्वॉल्व रहता है, कौन कौन स्पेशलिटीज इन्वॉल्व हो सकती है। एक तो स्ट्रेट फॉरवर्ड पीडियाट्रिशियन है ही या पीडियाट्रिक न्यूरोलॉजिस्ट। अगर कॉम्प्लेक्स इलनेस है डीएमडी वगैरह जैसे तो देन उसके सब स्पेशलिटीज है। आजकल बड़े शहरों में प्रैक्टिकली सभी जगह से फॉर इंस्टेंस न्यूरोमस्कुलर स्पेशलिस्ट है, मूवमेंट डिसऑर्डर स्पेशलिस्ट है, तो यू कैन प्रॉब्ली जैसे एपिलेप्सी है, सो you can probably the pediatrician pediatric neurologist to corresponding subspecialty उतना हो सकता है, वो नहीं तो कोई general adult neurologist के साथ हो। And as they go further forward, as things come to an end, it should be the responsibility of the carer at that time कि palliative care जो formal what we call specialist palliative care, unfortunately specialist palliative care at the moment ज्यादा करके कैंसर देखते हैं। एंड फ्रैंकली अगर मैं आपको बताऊं, दे आर नॉट वेरी कंफर्टेबल लुकिंग एट न्यूरोलॉजी, वो घबरा जाते हैं न्यूरोलॉजी बता के। उनके लिए कैंसर इज नाइस एंड इजी, उधर मॉर्फिन देना पड़ता है, अच्छी बात करनी पड़ती है, एंड देन द बायोलॉजी ऑफ द कैंसर टेक्स ओवर। जब न्यूरोलॉजी होता है तो एथिकल डिसीजंस होते हैं, कॉम्प्लिकेटेड डिसीजंस होते हैं, तो वो स्पेशलिस्ट पैलिएटिव केयर इज नॉट वेरी वेल इक्विप्ड टू हैंडल। So we have now a new developing subspecialty in neurology, which is called neuropalliative care, where people with neurology training are also given a basic training in palliative care. And आप देखोगे कि वो ट्रेनिंग एक्चुअली डायग्नोसिस से लेके लागू हो जाती है। अगर आपके पास ये ट्रेनिंग हो तो ब्रेकिंग बैड न्यूज इज नेचुरल, आप वहां से लेके यू विल गो ऑल द वे फॉरवर्ड। एंड देयर वाज वन पॉइंट आई फॉरगॉट to mention about breaking bad news. There's a goal to it which we are not often aware of, and that is trust. If you do it right, trust is built. आपको लॉन्ग टर्म रिलेशनशिप मेंटेन करनी है, तो वो ट्रस्ट अगर नहीं बनती है तो वो लॉन्ग टर्म रिलेशनशिप नहीं बनती है। सो रिमेंबर दैट ब्रेकिंग बैड न्यूज is has one last goal, and that is that it should end with trust on both sides. So ट्रांजिशनल केयर के बारे में और कुछ पूछना है कि वी मूव ऑन?
या ट्रांजिशन के नेक्स्ट क्वेश्चन, ट्रांजिशनल केयर का नेक्स्ट क्वेश्चन में है कि हाउ शुड वी एड्रेस द इशू ऑफ ट्रांजिशनल केयर एंड पेरेंट्स को कैसे बताएं उसके बारे में, मतलब दैट इज इम्पोर्टेंट, यू नो। आपने पीडियाट्रिशियन एडल्ट का रोल बता दिया है, करंट सिनेरियो क्या है? सिनेरियो तो ठीक नहीं है उतना ना, प्रॉपर्ली हो नहीं रहा है।
सो वो आई थिंक पेरेंट्स और एडोलेसेंट दोनों को बताना पड़ता है, और बताते हुए साइमल्टेनियसली करस्पॉन्डिंग एडल्ट प्रोवाइडर जो है उसको आइडेंटिफाई करना पड़ता है। और ये दिस हैज टू बी डन अ लिटिल सिस्टमैटिकली। सो ये आई थिंक अगर आप अमेरिकन एकेडमी का देखोगे तो देन दे हैव वेरी लॉन्ग प्रोटोकॉल्स। आई थिंक इंडिया के लिए एक सिंप्लीफाइड प्रोटोकॉल तो बनाना चाहिए विच शुड बी मेड अवेलेबल टू ऑल। एंड ये सिर्फ न्यूरोलॉजी के लिए तो नहीं है ना, आई मीन अस्थमा के लिए भी होगा, आई मीन सिस्टिक फाइब्रोसिस के लिए, देयर विल बी फॉर ऑल सीरियस इलनेसेस वेयर पेशेंट्स हैव टू ग्रो अप। I remember reading somewhere, I think it is in the Sick Kids website, that a child at the age of 14 or 15, they are told what to say if they have to access care on their own. This is my name. This is my illness. These are the medicines I'm taking. And the last I was admitted was with this. I mean, it's so simple. When do we ever do it? So, empowering the patient, empowering the family, and making sure that finally I believe that कि सब पेशेंट अपने खुद के जिंदगी के हकदार हैं. So as far as possible, we have to transfer this authority to them and empower them. I think that's the most important thing.
Yeah.
But ये DMD और SMA patients हैं, they are totally dependent on the parents. तो इसमें वो थोड़ा सा वो मतलब parents का ही rule रहेगा, because they are the care providers, because the children are dependent for all their activities of daily living mostly.
So I think.
Ma'am.
Sorry.
Just one point here. So this concept of these transition clinics is there, as you were saying. तो हम लोग का थोड़ा सा मुझे लगता है ज्यादा, जैसे सर कह रहे हैं ना, systematic involvement of the adult specialists probably has to be there. तो होता यही है कि प्रोबेबली अगर बच्चा 12, 13, 14 साल का भी हो गया और उसको कोई क्रॉनिक इलनेस है, तो वो ओवर प्रोटेक्टेड टाइप रहता है पेरेंट्स के साथ. तो और पेरेंट्स आर आल्सो कंफर्टेबल कि हम 5 साल की उम्र से यहीं दिखा रहे हैं, पीडियाट्रिक्स में ही दिखा रहे हैं, तो एक कंफर्ट जोन बन जाती है. तो आई थिंक some combined clinics for maybe at that time when sir is saying से 13-14 साल में शुरू हो गया, तो हमारा aspect और adults का aspect, so that they get used to this change, because उनको बड़ा odd लगता है suddenly कि अब उनको दूसरे clinic में refer कर दिया गया, अब 10 साल से तो हम यहीं दिखा रहे थे. तो that concept, like sir was saying, cystic fibrosis, so तो हमारे यहाँ pulmonology group है, they are trying, but again it is difficult. At times they have to admit patients जो 25-25 साल के हैं, उनको भी कई बार एडमिट करना पड़ता है. तो ये कॉन्सेप्ट किसी तरह सर हमें लाना पड़ेगा, ये ट्रांजिशन मिलके करना पड़ेगा, and then there can be a formal transfer, and obviously they will keep coming, as Shefali is saying, ki maybe just for some emotional support, even if not for specific treatment, they would keep coming. आपके जो primary doctor हैं, उनके साथ attachment कभी भी नहीं जाता है. That's what my feeling is, that they keep coming to you just to inform something, that they have that comfort zone with you. So that's, I think, important.
So there is one particular service which is called patient navigators. There's a course that's being run in Tata. It's abroad also. It's fairly. I personally think that is probably a pretty useful model to follow. And this is something that does not need to be specific to neurology. So you will have to identify patients who are really highly likely to need a greater attention. So perhaps you could triage them and prioritize those patients that would need this kind of specific transition planning. Baki to, India mein problem to wohi hai, we have to prioritize. I mean, we can't give everything to everyone.
Yeah. So now we will touch upon palliative care.
Okay.
So we would like to know, so what is palliative care and what is the parental perception regarding palliative care? And does palliative care have any role during the early phases of treatment of children with neuromuscular disorders like DMD and SM?
Okay. You can tell the next question also, sir. इकट्ठे बोल दो.
Yeah, बस वक्त खत्म हो रहा है.
So and the next question is, what is the current status of palliative care services in India for children suffering from disorders?
Okay. So the book definition of palliative care is the active total care applicable from the time of diagnosis, aimed at preserving and improving the quality of life of patients and their families facing serious life-limiting illness. And you do this through prevention and relief of suffering. And this suffering is of all kinds: pain, physical, psychological, social, spiritual. And the Indian definition actually adds that all of this should be socially acceptable and affordable. Now, the problem with palliative care is that as of now, India is a country with both low demand and low supply. There really is very low supply. So if you look at how many trained palliative care physicians there, we are just about, I'm not one, I'm a neurologist, but I am a supporter of the specialty. So I know कि 200 से 250 कुल मिला के हैं पूरे इंडिया में. Now the problem is, दूसरे side से the perception is कि palliative care is end of life care. And that is problematic. अगर आप कैंसर में देखो तो कैंसर में it's relatively simple कि एक स्टेज आता है जब ऑन्कोलॉजी पैलिएटिव केयर को हैंड ओवर करता है, and that is that. न्यूरोलॉजी में तो हम तो we have to apply this from diagnosis. We have to take our patients through the whole life journey. And see, so that is why I think you have to turn this around. And no longer, I think, should it be called a specialty. It has to be called an approach or an attitude. Once you pick it up, then you apply it from the beginning. And ideally, I personally think for neurology patients, we have to have these skills available to all neurologists. अगर आप specifically pediatric palliative care पूछोगे, तो नहीं के बराबर है. I mean, I can literally name the people on less than the fingers of one hand. General pediatric palliative care, there's Dr. Spandana Rayala in Hyderabad, and there's a Dr. Hari Krishna in Trivandrum. I am not sure if there's somebody who's trained both in pediatrics and palliative care. I mean, there are palliative care physicians who are interested in pediatrics, but people who have qualifications, both pediatrics and palliative care, only Spandana and Hari Krishna at the moment. Neuro palliative care, frankly, again, only two people, Dr. Shefali Gulati and Dr. Viraj Savni. One in Delhi, one in Mumbai. How much will these people do? So I think the important thing is for all of us to focus on propagating this information, training our residents in the basic bits and parts, communications. There's so much that can be done, and I try and explain to my residents that using these principles is just good neurology care. We are so used to making a complex diagnosis, and then after that, done. Thank you. Bye-bye. We are very comfortable with that. To go on from there and to, when you do this initial communication, the last thing you have to leave them with is the understanding that you will be with them, that you will not abandon them. So trust, the promise of non-abandonment, and the building of a long-term relationship. If you achieve that, then I think then your initial BBN then carries through to right till the end. I think I am at the end of the time of this.
Thank you. Thank you, sir. Abhi, I will ask Dr. Madhulika and you to give some final message, both in Hindi and English, so as to reach out to, Hindi as well as English speaking. Dr. Madhulika.
बहुत इंटरेस्टिंग सेशन था, बहुत सारी लर्निंग्स थी सभी लोगों के लिए. मैं ये कहना चाहूंगी, अगर हम अभी डीएमडी और एसएमए पे फोकस कर रहे हैं और अगर कुछ पेरेंट्स हैं जो इस सेशन में हैं, वो मुझे लगता है कि पेरेंट्स हैं सेशन में, तो मेरे ख्याल से जो मुख्य बातें बताई गई हैं वो ये है कि एक तो आपको अगर कोई भी सस्पिशन हो तो आपको जाके पहले तो डायग्नोसिस कंफर्म करना चाहिए. दूसरा ये है कि इंफॉर्मेशन आप जहां से भी लें वो सोर्स ठीक हो और गलत इंफॉर्मेशन से आपको भ्रमित नहीं होना है. तो ऐसी जगह जाए जहां से आपको सही इंफॉर्मेशन मिले. दूसरी बात ये है कि बच्चे के ट्रीटमेंट के विषय में, जैसे अभी बहुत सारे नए नए ट्रीटमेंट आ रहे हैं, उस सबसे हम बहुत ही खुश हैं. मतलब हम लोगों ने सोचा नहीं था कि पिछले 5-10 सालों में जितने ट्रीटमेंट आ गए बेंच टू बेड साइड, मैंने सोचा नहीं था कि जीन थेरेपी भी हम ऐसे देख लेंगे. पर उसके लिए हमें पेशेंस रखनी पड़ेगी, क्योंकि वो सब धीरे धीरे इवॉल्व हो रहे हैं और उनको आने में हमारे कंट्री में और अवेलेबिलिटी के लिए टाइम लगेगा. किस पेशेंट को फायदा होगा, किस पेशेंट को फायदा नहीं होगा, ये हम ब्लैंकेटली स्टेटमेंट नहीं दे सकते. वो सबका इंडिविजुअलाइज होता है. तो ये सोच के कि सबका एक स्पेसिफिक थेरेपी ही हमारा गोल होना चाहिए, कि जैसे स्किपिंग थेरेपी है तो हम अगर वो नहीं अवेलेबल हो रही है तो हम बाकी चीजों को भूल जाएं, ये नहीं होना चाहिए. क्योंकि सपोर्टिव केयर बहुत हेल्प करती है इन पेशेंट्स को इन द लॉन्ग रन, थेरेपी के लिए भी, कॉम्प्लिकेशंस प्रिवेंट करने के लिए भी. और दूसरा मैं ये कहना चाहूंगी कि फॉलोअप बहुत जरूरी है. अगर ये बताया गया है कि अभी क्योर नहीं है इस बीमारी का, इसका मतलब ये नहीं है कि हम रेगुलर फॉलोअप नहीं करें. रेगुलर फॉलोअप बहुत इंपॉर्टेंट है कॉम्प्लिकेशंस पिकअप करने के लिए, और किस स्टेज पे क्या करना है, आप ठीक से कर रहे हैं जो अभी तक आपको बताया, नई चीजें क्या है, इसके लिए भी मेरे ख्याल से बहुत जरूरी है कि आप इंटरनेट पर जाकर ऐसी इन्फॉर्मेशन ना लें जिससे कि आपको फिर कुछ गलत इन्फॉर्मेशन मिले। बेहतर है कि जहां आप दिखा रहे हैं वहां पे जाके डॉक्टर से बात करें कि अभी कुछ हो रहा है या नहीं हो रहा। वैसे वो आपको कांटेक्ट भी करेंगे अगर ऐसा कुछ हो रहा है, पर ये मुझे लगता है अच्छा है। और दूसरा जेनेटिक्स के बारे में, जैसा क्योंकि मैं जेनेटिक्स का पार्ट देखती हूँ, उसमें 2-3 चीजें बहुत इंपॉर्टेंट हैं कि जेनेटिक बीमारी अगर है तो परिवार में अगर आई है तो एसएमए के लिए जैसे मैंने बताया दोनों पेरेंट्स कैरियर होते हैं, तो उसमें ब्लेम करने की जरूरत नहीं है एक दूसरे को। वो एक नॉर्मल फिनोमिना है। कोई भी इंडिविजुअल 8 से 10 नुक्स वाले जीन का कैरियर हो सकता है, और अगर पार्टनर भी कैरियर है तो बच्चे में बीमारी आ सकती है। तो 25% चांस है। तो इंस्टेड ऑफ ब्लेमिंग कि ये आपकी वजह से आया है, ये आपकी वजह से आया है, हमारे फैमिली में तो ऐसा कुछ नहीं था, वो ठीक नहीं है, क्योंकि इसमें किसी का भी फॉल्ट नहीं है अगर वो कैरियर है। और इसके लिए जैसे डॉक्टर शेफाली ने कहा, ये पॉसिबिलिटी है कि अगले प्रेगनेंसी में हम टेस्ट कर दें, अगर आप चाहते हैं पता करना कि बच्चे में एसएमए की या डीएमडी की बीमारी है या नहीं है, और फिर आप फिर आप सोच सकते हैं कि आपको प्रेगनेंसी कंटिन्यू करनी है या नहीं करनी। तो वो अवेलेबिलिटी है हमारी कंट्री में, बहुत सारे सेंटर्स में वो अवेलेबिलिटी है। तो प्रिवेंशन के बाद ध्यान दें। और दूसरा जो अभी सर से भी बात हो रही थी कि जो हो गया है या लेट डायग्नोसिस हुआ या कैरियर स्टेटस पता नहीं लगा, उसके बारे में सोचने का फायदा नहीं है। अब हमें आगे बढ़ना है। जो हमारा स्टेटस है बच्चे का, उसको लेकर जो बेस्ट हम कर सकते हैं फैमिली के लिए, वो हमें करना है। और नीडलेस टू से कि जो भी डॉक्टर्स आपको देखते हैं वो सब आपके साथ है। जैसे सर ने एक बहुत अच्छी बात कही एंड में कि हमें ये आश्वासन सभी को देना बहुत जरूरी है कि जो भी स्थिति है, अवेलेबिलिटी ऑफ ट्रीटमेंट, नॉन अवेलेबिलिटी ऑफ ट्रीटमेंट, किस स्टेज में आप बच्चे को लेके आए हैं, हम सब आपके साथ हैं, पर आपका भी कोऑपरेशन हमको चाहिए उसके लिए। तो ये हमें एक्सेप्ट करनी पड़ेगी दोनों तरफ से, क्लिनिशियन की तरफ से, पेरेंट्स की तरफ से, बीमारी क्या है और उसके लिए बेस्ट पॉसिबल ऑप्शन अभी क्या है। तो आई थिंक हम सब साथ में काम करेंगे तो इन सब बीमारियों के लिए जरूर कुछ ना कुछ हल निकलने लगेगा, जैसे आप कुछ पिछले सालों में देख रहे हैं। तो मेरी तरफ से बहुत सारी शुभकामनाएं सबको, और सब लोग मिलके काम करेंगे तो आगे का टाइम बहुत ही अच्छा होने वाला है, ऐसा मुझे पूरा विश्वास है। थैंक
यू मैम। अभी आप लॉग आउट मत करना मैम, बिकॉज अभी डॉक्टर गुरसानी का कमेंट लेके डॉक्टर वी आर रनिंग शॉर्ट ऑफ टाइम, सर का कमेंट लेके।
हाँ बिल्कुल बिल्कुल, नो इश्यूज।
डॉक्टर काकुली विल पुट इन अ पोल एंड जो क्वेश्चंस है वो लेंगे, इसलिए सर योर फाइनल मैसेज।
ओके, तो डॉक्टर मधुलिका ने तो आपको काफी कुछ समझा दिया है। मेरे लिए सिर्फ एक बची बात कहने की है कि आपकी उम्र बढ़ने वाली है, आपके बच्चे की उम्र बढ़ने वाली है, इसकी तैयारी करना बहुत जरूरी है। और साथ साथ में डॉक्टर के साथ मिलकर ये देखना है कि आपका बच्चा खुद के पैरों पर, खुद की जितनी जिम्मेदारी ले सके, हम वो कैसे कर सकें। क्योंकि उम्र बढ़ती है तो आपके भी कंधे उतना तो सपोर्ट लगेगा ही आपको। सो ये प्रेपरेशन, ऐसा ये मत सोचो कि ये ना सोचेंगे तो नहीं होगा, तो करना ही पड़ेगा। ठीक है, थैंक यू शेफाली।
Thank you, sir. And sir, we'll just take the questions that Dr. Kakuli lenge. We are also having live streaming of all these sessions on YouTube. So the YouTube link is there. So it will be there, and they will be on our website as well as Global Genes website in the US for all the sessions. So uske anybody who has not been attending, can attend. Dr. Kakuli, please. I know we have over a short time, and thanks Dr. Lokesh Lingappa and Dr. Vishal and Mahesh for joining. We'll just wind up in 2 minutes. Sorry.
We just have the polls related to this first session. Kindly go through it, and I'll just give 3 to 4 minutes for finishing the poll. Then we can resume the second session. And we'll also go through the question and answers.
You can see the questions meanwhile as the people are doing the poll.
Sure. There are the questions.
There is one question I'll read through. I think parent advocacy group can be made to address the breaking of the bad news and counseling both.
Breaking of the bad news ke liye, I will ask both of your comments, Dr. Gursani, Dr. Madhulika. I mean, breaking of the bad news mein to will first have to be done by the doctor only and the team diagnosing it. बाद वाले में आगे वाले जो
एग्री
सीक्वेंशियल में वी कैन इन्वॉल्व द पेरेंट सपोर्ट ग्रुप, जिसमें से कोपिंग स्ट्रेटजीज एंड दे नो दे आर नॉट अलोन.
बिल्कुल, they are not alone and they can learn from each other how they are coping up and what they are doing.
Yeah,
agree Shefali. Yeah,
next question, Dr. Kakali.
Next question, and identity of caregiver has asked, how do you proceed with the newly diagnosed cases? I think that is pretty much covered already in the questions we had. The next question we have,
actually,
what is the DMD life expectancy? And what it would be like if proper care is given? Are there any kids who are surviving beyond 25 years? So this is a question, sir, or Dr. Madhulika, can you please answer this?
Shefali can answer, sir can answer.
Okay. Generally, generally, ना जो 13-14 years पे most of them जो हम steroid भी दे रहे होते हैं, they become non-ambulatory, they start having respiratory issues and all that, and very less number will go to the second decade of life. But yes, if you provide respiratory support, they will. But हमारे यहाँ उतना नहीं होता है, because we are not providing, but we are ensuring, we have been asking कि हमें holistic multidisciplinary management करना है, तो वो respiratory support वगैरह कल sessions में बात हुआ है, तो उससे भी expect कि they will be going into they will be going into the 20 to 30 thing. Beyond that, I have not seen. Dr. Goswami, have you seen anybody beyond that?
No.
I think because of respiratory support हम लोग नहीं देते हैं, उसके ऊपर वो नहीं चल रहा था, which we are advocating now.
Yeah.
So we have a similar question pertaining to the answers which Dr. Shefali and you are giving, sir. Survival becomes very difficult for a rare disease patient, mentally, socially, and economically. If there is no parental support or no parents there, how does one deal with this thought? Please suggest psychological and possible solution for the patient.
20th webinar जो है is going to cover that. अगर आप वो series of webinars देखिए, तो हमने बहुत सोच समझ के सारे एस्पेक्ट्स कवर किए. फर्स्ट 2 सेशंस 10th को था, वो सारा बताया, करंट एडवांसेस वगैरह के ऊपर सारा अबाउट डायग्नोसिंग मैनेजमेंट. 2 वेबिनार्स कल हम लोगों ने होलिस्टिक मैनेजमेंट पे, फिर वो क्या मिथ्स है ड्रग्स ट्रीटमेंट पे वो हुआ, और मॉर्निंग में अभी ये सारा जो हम बात कभी भी नहीं करते, ब्रेकिंग द बैड न्यूज, ट्रांजिशनल पैलिएटिव केयर, तो आप करोगे तो कोपिंग स्ट्रैटेजीज वही हम बात कर रहे हैं, वो लास्ट वाले में होंगे. अभी जो नेक्स्ट सेशन बहुत इंपॉर्टेंट है, जो हमारे पैनलिस्ट ज्वाइन किए, उसमें भी आपको बहुत कैसे एथिक्स है, एथिकल इश्यूज क्या है, स्टिग्मा जो अटैच्ड होता है ये सारी चीजों से, किसी को व्हील चेयर में देखा, कुछ भी देखा, वो सब, और कैसे ह्यूमनिस्टिक अप्रोच, उसमें आपको समझ आएगा. तो कोपिंग स्ट्रैटेजीज का लास्ट वेबिनार है काफी. नेक्स्ट
काइंडली आप लोग बने रहिए इसी सीरीज में, क्योंकि जो सारे 20 वेबिनार्स हैं, जो सेशंस हैं, सारे में आपके जो इस तरह के क्वेश्चंस है किसी न किसी पार्ट में एड्रेस किए जा रहे हैं. तो आप लोग बने रहिए, क्योंकि वी हैव एक्सपर्ट पैनलिस्ट हु आर एड्रेसिंग इट. काइंडली टेक एडवांटेज ऑफ दैट.
वन मोर थिंग आई वांट टू ऐड, क्योंकि हमने जैसे नेक्स्ट वीक में हमने एक तो रिसर्च के ऊपर लिया है जो डॉक्टर खादिलकर लीड कर रहे हैं, फिर गवर्नमेंट ऑफ इंडिया रेयर डिजीज पॉलिसी के बारे में है, मधुलिका मैम भी होंगे उसके अंदर. साथ में जो कॉस्ट की इश्यूज होते हैं, इंश्योरेंस वगैरह के इश्यूज हैं, उसके लिए वी हैव सम वेरी बिग स्पेशलिस्ट कमिंग एंड टॉकिंग ओवर इट. एंड फिर पेरेंट सपोर्ट ग्रुप्स का है, फार्मा इंडस्ट्रीज का क्या रोल है, तो हमने मल्टीनेशनल कंपनीज को बाहर से भी बुलाया है टू टॉक अबाउट इट, मतलब ऑनलाइन. एंड मीडिया का क्या रोल है, एनजीओज का, इंडियन एनजीओज एंड अब्रॉड के एनजीओ से कैसे हम समझ सकते हैं, क्या सपोर्ट आपको मिल सकता है, वर्ल्ड ओवर क्या हो रहा है, क्राउड फंडिंग क्या है, सेल्फ एंड पेरेंट एडवोकेसी क्या है, और ह्यूमैनिटेरियन एक्सेस प्रोग्राम्स, एम्प्लॉइज बेनिफिशियरी स्कीम्स, और लास्ट में पेरेंटल काउंसलिंग एंड कोपिंग स्ट्रैटेजीज, बिकॉज वो मैसेज बहुत ही इंपॉर्टेंट है. तो वो आप सब कवर होंगे आपके इश्यूज. कैन यू वाइंड अप? इट्स वेरी
The parent who has written his son is 4-year-old and is suffering from SMA KCNQ2 mutation. What is the treatment available? What best I can do for the son?
Shefali, this is for you.
I think there is some issue with the diagnosis, what you're saying, because they are SMA, some other thing, and the other an epileptic encephalopathy. So maybe, but there is a possibility you may have two, like we have patients, with 2 conditions happening. So that will have to be individualized. तो आप हमारे को मेल कर दीजिएगा, या आप अपना चैट में नंबर डाल सकते हैं टू हमारा जो मेन है, देन वी विल आवर साइड विल कॉल यू. आप डाल दीजिए अपना मोबाइल नंबर डायरेक्ट में, नॉट टू एवरीवन. तो उसमें we will contact with. There might be two conditions. I think we're running 15 minutes behind schedule, so I think we'll request Dr.
Poll is running. We'll just take 1 more minute for the poll. I think we have to send it to the poll. We'll just finish the poll in 1 minute, and then we'll move to the next session.
You can thank the panelists. You can meanwhile thank
all the panelists, Dr. Gulsani and Dr. Madhulika
and Dr. Nirmal Surya.
Thank you.
Thanks a lot. Thank you very much, sir.
Thank you.
Chalo.
Bye. Thank you.
More for your inputs. Kindly do attend the poll also, so that we have few things, how good we were delivering the session. That will give us some idea about it.
Grateful
Okay, we are waiting for the polls.
It is already launched, sir.
Okay.
Results.
Yeah, but as it says, the host. Yeah. Host and panelists can't vote.
Okay. Obviously, panelists can't vote. Panelists अपने लिए थोड़ी vote करेगा कि मैं बहुत अच्छा हूँ.
नहीं.
Thanks a lot, sir. Thanks a lot.
Thanks, ma'am.
Thank you. Bye.
Okay. Bye.
Yeah. Please welcome Dr. Mahesh, Dr. Lokesh, and Dr. Vishal Soni. Sorry, it first time only short by 15 minutes. It's not short. I think because the previous issues were breaking the bad news, transitional palliative care, breaking the bad news took a lot of long time. My apologies to Dr. Lokesh, Dr. Mahesh, and Dr. Vishal. So we will start, Dr.
Yeah, we'll start. A very good afternoon to all of you. And thanks for joining this session. The session will basically focus on ethical issues, destigmatization, and humanistic aspects. Today we have in the panel is Dr. Vishal Sondi. He is a pediatric neurologist and currently works at AIIMS Pune. His area of interest includes neurosciences, especially neuroimmunology and epilepsy. Dr. Lokesh Lingappa is a senior pediatric neurologist at Rainbow Children Hospital, Hyderabad. He complements his clinical practice with metabolic and genetic team and pediatric psychiatrist team. Dr. B. Vishwanathan, he wanted to join, but due to paucity of time and all, he might join later. We have Dr. Mahesh Kamate, is a professor at JN Medical College, Belgaum, and has more than 25 years of experience. He has many awards and has published many research articles in international and national journals.
And Dr. Rakesh Luda will also be joining us. He's a professor and my MBBS batchmate, and he's pulmonology and intensive care, and he's currently also in the ethics committee of AIIMS. He'll be joining only around 12 because he's in the PICU. And Dr. Vishwanathan is basically traveling. He may be able to join. Thank you so much, and we'll start off the questions. Gautam.
Good morning. So what are the ethical issues? What are the ethical issues that needs to be taken care of while antenatal counseling of a mother who has a child affected with DMD, and a similar scenario where the mother has a child affected with SMA? This question is directed to Vishal.
Yeah, thank you, ma'am, and thank you everybody for inviting me over. So the ethical issues regarding antenatal counseling is that we have to make the parents understand what is the actual disease of the child, ki bachche ko problem kya hai. So they have to first understand what is the disease in the first child and how the muscles work. So in a healthy person, the electric signals from the brain, they are transmitted through the spinal cord, through the nerve, and then they reach the muscles, and then the muscles are stimulated and they contract and work. And along the way, the nerves have to be in a good order. The muscles have to accept the signals and then generate a response. So if brain or spinal cord is damaged, then the electrical signals are not generated at all. And if the nerves are damaged, then the signals will not reach the muscles. And if the muscles are abnormal, then despite the signal, they'll not be able to contract. तो अगर इस पूरी एक्सिस में कहीं पे भी प्रॉब्लम है तो मसल्स जो है अपना काम नहीं कर पाएंगे. SMA में प्रॉब्लम जो है नर्व लेवल पे होती है, जिससे कि सिग्नल जो है मसल तक पहुंच नहीं पाता है, जबकि डीएमडी में प्रॉब्लम मसल्स में होती है, जिसमें सिग्नल मिलते हुए भी मसल्स जो है कंट्रैक्ट नहीं कर पाते हैं। तो और ये दोनों रीजंस, दोनों बीमारियां जो है जेनेटिक रीजन से होती हैं। जो डीएमडी है वो यूजुअली मदर के थ्रू आती है, और एसएमए जो है वो दोनों पेरेंट्स की वजह से, दोनों पेरेंट्स जो हैं कैरियर्स होते हैं, दोनों पेरेंट्स एक एक जीन देते हैं और बच्चे को तब ये प्रॉब्लम होती है। तो अगर एक बच्चे को डीएमडी है तो दूसरे बच्चे को डीएमडी होने का रिस्क 50% है, जिसका मतलब है अगर बच्चा लड़का होगा तो उसको डीएमडी होगा, अगर बच्चा लड़की होगा तो उसको डीएमडी का कैरियर होगा वो। तो पेरेंट्स को ये मैथमेटिक्स समझना जरूरी है, बट उससे भी ज्यादा जरूरी है कि उस बच्चे के लिए चांस सिर्फ यही है कि या तो बीमारी होगी या नहीं होगी। और इस कंडीशन में टाइम पर पेट में ही बच्चे का टेस्टिंग कर लेना जरूरी है। यूजुअली हम बोलते हैं कि मदर जैसे ही प्रेग्नेंट हो, प्रेगनेंसी का पता चले, वो नियरेस्ट अपने गायनेकोलॉजिस्ट के पास जाके उनसे कंसल्ट करें, उनको बताएं कि पहले बच्चे को ये प्रॉब्लम था, तो अगले बच्चे के लिए पेट में टेस्टिंग के लिए बताया हुआ है। और अगर पेट में बच्चे को ये प्रॉब्लम डिटेक्ट होती है तो वो ऑप्शन पेरेंट्स के पास होता है कि वो अबॉर्शन कराना चाहते हैं, टर्मिनेट करना चाहते हैं कि नहीं चाहते हैं। तो वो डिसीजन जो है फाइनली पेरेंट्स के पास रेस्ट करता है। बट बहुत बार हम मैथमेटिकल मॉडल में कई बार समझा रहे होते हैं कि रिस्क 25% है, रिस्क 50% है, बट ये जानना जरूरी है कि चाहे एक जो भी रिस्क है उस बच्चे के लिए तो या तो बीमारी होगी या उसको बीमारी नहीं होगी, और उसका पता सिर्फ एक ही तरह से लग सकता है, वो जेनेटिक टेस्टिंग करने का, फीटस का जेनेटिक टेस्टिंग करने का, जब बच्चा पेट में है। उसके बाद डिसीजन पेरेंट्स का है कि वो अबॉर्शन करना चाहते हैं कि नहीं करना चाहते हैं।
Dr. Vishal, is it okay if you switch on your video?
Ma'am, I'm in the OPD, ma'am. I'll just see. Haan ji.
Next question, Dr. Gautam. Yeah, thanks.
So the next question is
humanistic touch, no? I think.
So the question is, what are the ethical and legal issues pertaining to the drug trials for the newer drugs in DMD and SMA? What are the rights of patients and their parents in such drug trials? This is again directed to you, sir.
Okay. Now, जो DMD और SMA के ड्रग ट्रायल्स हैं वो बाकी ड्रग ट्रायल से थोड़ा डिफरेंट हैं, बिकॉज इसमें हम ये एक तो जेनेटिक बीमारियां हैं और इसमें हम जीन्स को मॉडिफाई कर रहे हैं ताकि जो प्रोटीन जीन्स नहीं बना पा रहे हैं वो अपना वो प्रोटीन्स वो बनाना शुरू कर दें। अब इसमें एज अ पेशेंट या एज पेरेंट ऑफ अ पेशेंट आपके लिए समझना जरूरी है कि वो एक्सपेरिमेंट क्या है, वो एक्सपेरिमेंट कैसे करेंगे, दवाई कितने टाइम तक चलेगी, और दवाई अगर काम नहीं करी तो नुकसान क्या क्या है उसके। सबसे पहले उसका नुकसान क्या है वो समझना बहुत जरूरी है, और आपके पास ये ऑप्शन हमेशा होना चाहिए कि आप बीच में भी उस दवाई के लिए मना कर सकें। यू कैन विड्रॉ फ्रॉम द ट्रायल इवन इन बिटवीन व्हेन द स्टडी इज गोइंग ऑन। दूसरी चीज, अगर वो दवाई फायदा करती है तो वो फायदा किस तरह का है, क्या एंड पॉइंट क्या है। अब जैसे डीएमडी में बहुत सारे ट्रायल्स हुए जिसमें उन्होंने बोला वो प्रोटीन बनाना वो शुरू कर देते हैं, कि वो दवाई देते हैं और जो डिस्ट्रोफिन जीन की कमी है वो जीन डालने के बाद डिस्ट्रोफिन बनना शुरू हो जाता है। पर वो डिस्ट्रोफिन बनने के बावजूद जो बच्चे चल नहीं पाते थे उन्होंने फिर भी चलना नहीं शुरू किया, या जो चल रहे थे वो फिर भी उनका डिक्लाइन जो है वो वैसे ही होता रहा। तो ये तो स्टडी का एंड पॉइंट क्या है? स्टडी का एंड पॉइंट वो सिर्फ ये देख रहे हैं कि हाँ जीन बॉडी में इंट्रोड्यूस करने के बाद या वो जीन थेरेपी के बाद डिस्ट्रोफिन बनना शुरू हो गया है, या एंड पॉइंट वो देख रहे हैं कि हाँ कितने टाइम तक बच्चा चल सकता है या चलने में कोई इंप्रूवमेंट आता है कि नहीं आता है। तो क्लिनिकल इंप्रूवमेंट हो रहा है कि प्रोटीन्स में इंप्रूवमेंट हो रहा है। तो ये अंडरस्टैंड करना बहुत जरूरी है अप फ्रंट सभी पेरेंट्स के लिए, क्योंकि बाद में जाके फिर ये चीज तंग करती है कि आपने ट्रायल में पार्टिसिपेट भी कर लिया, बहुत पेनफुल एक्सपीरियंस भी रहा, तो आपकी एक्सपेक्टेशंस ठीक रहती हैं। एंड सेकंड वेरी इंपॉर्टेंट व्हिच इज बोथ अ लीगल एज वेल एज एक्सपेरिमेंटल थिंग which one has to consider is कि मान लीजिए एक दवाई का फायदा हुआ और वो ट्रायल खत्म हो गया, उसके बाद वो दवाई कैसे मिलेगी? क्या वो दवाई आपको आगे भी मिलती रहेगी फ्री ऑफ कॉस्ट जब तक बच्चा है, या फिर वो सिर्फ ट्रायल के दौरान आपको दवाई दी जाएगी और उसके बाद आपको खुद से परचेज करनी पड़ेगी, आपको ऑल्टरनेट सोर्स ढूंढना पड़ेगा? क्योंकि ये चीज पहले क्लैरिफाई कर लेना बेटर है, बिकॉज एक बार ट्रायल खत्म हो गया, फिर वो जो कंपनी ट्रायल कर रही थी उसके रोल से आप हट जाएंगे। फिर आपको वो दवाई कैसे प्रोक्योर करनी है वो अंडरस्टैंड करना जरूरी है। तो ये टर्म्स एंड कंडीशंस पहले क्लैरिफाई कर लेना इंपॉर्टेंट होता है।
एब्सोल्युटली, बहुत बहुत इंपॉर्टेंट बात बताई डॉक्टर विशाला, एंड थैंक यू सो मच। आप ओपीडी के, डिस्पाइट बीइंग एन ओपीडी, यू हैव बीन एबल टू जॉइन अस एंड give your valuable suggestions. Really eternally grateful to you. Thank you Vishal. Dr. Lokesh, Dr. Gautam आपसे सवाल पूछेंगे।
So, a mother of a child suffering from DMD visits her child's physician in the OPD. She says, "Doctor, one of my relatives was saying that she knows a kid who got cured of DMD by receiving stem cell therapy, and that my kid should also be receiving the same. So what should be the most appropriate reply by the physician to the mother?"
So the stem cell transplant जो है आजकल सारी चीजों के लिए सर्वरोग निवारणी बोलते हैं ना, ऐसे ट्राई कर रहे हैं। So it is not true. कुछ ही सिचुएशंस में थोड़ा सा फायदा हो सकता है स्टेम सेल का, लेकिन डुशेन्स मस्कुलर डिस्ट्रोफी या स्पाइनल मस्कुलर एट्रोफी में उसका कोई रोल नहीं है। अगर ऐसे है तो पूरा दुनिया यही चीज यूज कर रहा होता था एंड कोई रिसर्च नहीं करने की जरूरत नहीं पड़ता था। क्यों इतना साइंटिस्ट इतने करोड़ों में डॉलर्स में ये करके रिसर्च कर रहे? इसलिए कि वो आंसर नहीं है, क्यूर नहीं है। स्टेम सेल ट्रांसप्लांट इज नॉट ए क्यूर फॉर आइदर डुशेन्स और स्पाइनल मस्कुलर डिस्ट्रोफी कंडीशंस के लिए, क्योंकि जो मैकेनिज्म ऑफ जो स्टेम सेल हम देते हैं, ये जो जैसे ब्लड कैंसर्स के लिए बोन मैरो ट्रांसप्लांट करते थे या और कोई कैंसर्स के लिए बोन मैरो ट्रांसप्लांट करते हैं, वो अलग मैकेनिज्म है, वहाँ पे बीमारी अलग है, उसमें वो क्यूर करता है, हेल्प करता है। वेराज मस्कुलर डिस्ट्रोफीज में या स्पाइनल मस्कुलर एट्रोफी में ये जो स्टेम सेल, जो ऑटोलॉगस स्टेम सेल करते हैं या मेसेंकाइमल स्टेम सेल ट्रांसप्लांट बोलते हैं, इसका कोई भी रोल नहीं है, तो वो यूज नहीं होता है ऐसे बच्चों में। सो वी शुड नॉट बी डूइंग इट।
ये बहुत इम्पोर्टेंट है बिकॉज डॉक्टर लोकेश, आप देखते हो हमारे कई पेशेंट्स हैं, वो कहीं कहीं से करा के आते हैं, फिर वो बोलते हैं कि पेशेंट्स को तो फायदा हो रहा है। सो इट बिकम्स अ वेरी बिग डायलेमा टू एक्सप्लेन। तो हम अगर बताते हैं, हमें साइंटिफिकली जब बता रहे हैं, आपको कुछ भी ऐसे पता चलता है कि न्यू ट्रीटमेंट, वो जाने से पहले आप अपने डॉक्टर के पास वापस आइए, ट्राई टू अंडरस्टैंड कि उसके पीछे साइंस क्या है, क्योंकि हमें मालूम नहीं होता है कि कई चीजें जो बताई जा रही हैं वो आपको एक कमर्शियल लेवल में मार्केटिंग स्ट्रैटेजी में बताई जा रही है, तो आपको वो देखना पड़ेगा। और आपके जो डॉक्टर हैं जिनके साथ आप दिखा रहे हैं और ट्रस्ट है, उनसे प्लीज क्लैरिफाई करिए। जैसे डॉक्टर लोकेश ने बताया कि रिसर्च इज ऑन, अभी मे बी फ्यूचर में आए, पर अभी भी एज ऑफ टुडे कोई भी डीएमडी एसएमए में रोल नहीं है। देयर इज लॉट ऑफ स्टडीज गोइंग ऑन, राइट डॉक्टर लोकेश? बट यू नो, मतलब
या और एक चीज आप नोट करेंगे, आजकल क्या जो भी स्टेम सेल का ये हो रहे, दे आर कमिंग टू द फिजियोथेरेपी यूनिट्स, दे आर नॉट गोइंग टू डॉक्टर्स, दे आर मार्केटिंग टू द फिजियोथेरेपी एंड रिहैबिलिटेशन यूनिट्स, so which is bypassing the doctor who makes the decision. I think this is a thing which we need to avoid, and scientific advice, जैसे डॉक्टर शिफा ने ऑलरेडी बोले, scientific advice देके, if there is a role as a doctor, as a clinician, we will know whether it is helpful, we'll be aware of the clinical trials, उसके हिसाब से आपको suggest करेंगे. So please always consult your physician, clinician, whosoever is there, and then take these steps. See, because ठीक है, कुछ harm नहीं है, ना कर लेते हैं, क्या होगा? Don't have that attitude, because अगर कुछ फायदा होगा तभी करना है ऐसे situation पे. We should not be just doing this stem cell transplant.
And one thing more कि जो ट्रीटमेंट के डिसीजंस हैं, डॉक्टर्स हैं वो ट्रेंड हैं, कोई थेरेपिस्ट के अगेंस्ट कुछ चीज नहीं है, पर उनकी ट्रेनिंग में ये ट्रीटमेंट ऑप्शंस नहीं होते हैं। तो आपको, क्योंकि पेरेंट्स को होपफुल रहना है, पर ये नहीं है ना कि आप कहते हैं ना डूबते कोई तिनका का सहारा है, यू नो, यू क्लचिंग एट स्ट्रॉज ऑल द टाइम। लेकिन जब कोई उसका एविडेंस नहीं है, सिर्फ होप विदाउट साइंस इज नॉट रैशनल।
Absolutely.
Thank you. Next question, Dr. Gautam to Dr. Mahesh.
So what are the social and psychological issues faced by the parents and the child who is suffering from neuromuscular disorder like DMD or SMA? And what are the various social stigmas faced by them?
Yeah, DMD में जो protein होता है dystrophin protein, it is not there only in the muscle. It is also there in the brain and the heart also. So because of this abnormal dystrophin in the brain, many children with Duchenne muscular dystrophy can have some amount of cognitive impairment in the form of intellectual disability. They can also have behavioral issues like ADHD and even sometimes autism also. So because of this, their learning, their understanding can get affected. So when children with the DMD attend to school, they may not perform as well as their peers. So this needs to be understood by the parents. And if they're not performing on par with their peers, they need special help in the form of psychological evaluation and even support by special educators and psychologists. For some behavioral disorders like ADHD, we can use some drugs also, which can improve their hyperactive behavior.
Thank you. Besides this, ना डॉक्टर महेश, पेरेंट्स के लिए, पेरेंट्स के अंदर क्या हो सकता है? दिस इज, ये तो चाइल्ड में हो सकता है उनकी, बिकॉज पेरेंट्स को एक बच्चे को जो वो सोच रहे थे कि टिपिकली डेवलपिंग बच्चा है, उनको फिर सपोर्ट करेगा बुढ़ापे में, ओल्ड एज में दे विल बी सपोर्टिंग, बट यहाँ रिवर्सल ऑफ रोल्स हो रहा है, आपको ही सपोर्ट करना है और आपको उनको ज्यादा सपोर्ट करना है, बिकॉज दैट, हाउ टू हैंडल दैट?
Ma'am, as we know, both this DMD, SMA, they're all permanent disorders. As of now, there is no cure for these conditions, and they're progressive conditions. यानी कि दिन ब दिन बच्चे के problems और बढ़ते ही जाने वाले हैं. And taking care of a child with special needs or disability is going to take a toll on parents also. Many times, one of the parents has to leave a job and they need to stay back at home. Okay? And they even have to face a lot of stigma, both financial and emotional load will be there on the family. And because of this, there can be a lot of conflicts in the parents, a lot of stresses in the parents like depression, anxiety. This also sort of can come up in parents. And when these issues are there in parents, it's advisable that parents also take help by professionals like a psychologist or a psychiatrist, so that they get good support. And even sometimes we can even use some medicines to take care of these problems in the parents also.
It's very important because कभी भी वो लोग मॉल्स में ले जाते हैं, कुछ है या कहीं पे भी जा रहे हैं पब्लिक प्लेस में, तो किसी को भी व्हील चेयर पे ले जा रहे हैं और तो पेरेंट्स को मोस्ट प्रॉब्लम होती है वैसे भी, बिकॉज नेविगेट करने के लिए वैसे भी इतने फ्रेंडली एटमोस्फियर भी नहीं है, और उसमें पीपल्स एटीट्यूड भी ठीक नहीं है, वो लोग बड़े अजीब वे में देखते हैं किसी को. सो बेसिकली कोई भी कंडीशन है, उसके अलावा उसके पेरेंट्स को क्या उस पर पड़ेगा इफेक्ट और बच्चे पे पड़ेगा विल डिपेंड ऑन द इन्वायरमेंट एंड द एटीट्यूड ऑफ पीपल अराउंड. सो आई थिंक वी हैव टू एज अ जनरल पब्लिक, जिनके बच्चे गॉड विलिंग सब ठीक है, शुड अंडरस्टैंड कि इनकी गलती नहीं है और उनको सपोर्ट करें ना. आई थिंक दैट वुड बी इम्पोर्टेंट. व्हाट डू यू से?
One point I want to make out is काफी बार then the school is also not very supportive. Sometimes there is a child of DMD and his class is in the first floor, and the school authorities are not even willing to shift that class to the ground floor. And because of this problem also, many children have to drop out of school. Despite request, the school authorities are not that cooperative, and they don't wish to shift the class to the ground floor, or they're not cooperative in taking these students to the school. They just openly say that बच्चे को आप घर लेके जाओ. So by this attitude, many of the children with DMD get discriminated in the school also. So we need to educate the parents, the school authorities, and even the public, so that we should help the maximum, so even these children get some sort of education also.
एब्सोल्युटली. और इन सब सिचुएशन में ना हम लोग जो इक्वालिटी की बात करते हैं कि हमारा सब राइट है इक्वालिटी, यहाँ पे इक्वालिटी नहीं इक्विटी की बात करनी है, बिकॉज अभी हमें नहीं पता है कि व्हील चेयर पे बैठ के क्या प्रॉब्लम होती है, वो बच्चा नहीं उठ पा रहा है, उसकी क्या प्रॉब्लम है, तो उसको ज्यादा सपोर्ट चाहिए. दैट मीन्स टू रीच अ पर्टिकुलर थिंग उसको ज्यादा सपोर्ट चाहिए, तो इक्विटी इज इम्पोर्टेंट इन दैट. डॉक्टर गौतम, नेक्स्ट क्वेश्चन फॉर डॉक्टर लोकेश.
What is caregiver burnout and how can it be prevented? What is the role of a physician and psychologist in handling these issues? Dr. Lokesh.
Dr. Lokesh?
So we are audible, sir?
Dr. Lokesh? Yeah.
Can we repeat the question? Sorry.
Yeah.
So what is caregiver burnout and how can it be prevented? What is the role of a physician and psychologist in handling these issues of caregiver burnout?
In the background of a mother of 2 young boys, both of them have DMD and are non-ambulatory. And then now she's becoming very tired and all. And yeah. And it has a negative feeling towards the children who actually she has been bringing them up.
Huge challenge for both the parents, especially the mother. And in Western world, there are support systems where the caregivers are given a day off, at least in a month's time or in 2 months' time. At least one day for morning, they leave at a place where the kids are taken care of. There is an environment which is supportive to these kids, and parents know it is safe to leave them there. And then respite care kind of thing, which actually helps them to have at least one full day off in a month at least, or in a 2 months, where they don't have to feel guilty about it. They just have to have a break. They are humans as at the end of the day. And the way they serve these children is almost like godly. They don't take any rest 24/7. They are taking care of these children, and they need rest and they need support from the society, and from every angle the support needs to be given for these families. So either the government on a larger scale should take in some step to set up this respite care. It might not be specific to Duchenne's muscular dystrophy, but for any children with disabilities which require constant support, there need to be a complete respite care so that they can be able to have this one day recoup and then come back with some energy. Like all of us have Sundays. These parents don't have Sundays or Saturdays to recoup from this care burden and come back and give the care. So I think that is very important part of this one. As a doctor, clinician, we can guide through some of the NGOs where there are some respite cares provided by the NGOs. But at a governmental level, this has to happen to reach every corner of the country, because it cannot be done in just small elite pockets of the cities where these services are available. So I think there is a lot of work that needs to be done on this front. The psychologist can share talk to the families and share the psychological burden of the family. But physically also they need a respite. They need a day off from the care, and having not to feel bad about taking off from the care. So I think that has to be on a larger scale, need to be worked on in collaboration with the government on a larger scale.
Yeah, and the other thing is we in India there is a dearth of care providers, those trained helps, because here if although in India they say you get a lot of helps, you get helps for household things and minor orthopedic problems if somebody's had a fracture or something, but somebody who needs a child on a who needs to be on a wheelchair, needs to have physiotherapy, needs to have respiratory care. We have difficulty in finding, the trained care providers, who can help and all. So that is also a big dearth. Patients को बहुत problem होती है कि कैसे support करने के लिए, उनको घर में help करने के लिए मिल जाता है, घर के काम के लिए, या कुछ और कुछ हड्डी किसी का टूटा है, फ्रैक्चर है, या किसी का नी जॉइंट रिप्लेस हो गया, वो सब के लिए मिल जाते हैं. पर ऐसे व्हील चेयर के जो बच्चे हैं और कईयों में आदमी अब रेस्पिरेटरी सपोर्ट भी देना है, एक्सरसाइजेस करनी है, तो वो सब में प्रॉब्लम है. डोंट यू थिंक डॉक्टर लोकेश समथिंग हैज टू बी डन फॉर दैट आल्सो?
Absolutely, it's a major caregiver support system. Even to get them out onto footpath, there are no footpaths in our country to get these children out onto the roads, and this one, it's a nightmare for people with disabilities. That's why the visibility of these children are so low, or these families are so low out in the society, because we are not creating an environment which is disability friendly. I think we should start from there to help these families, because they also do need to have a similar kind of, they are cognitively so good, so they need to have that opportunity to have a participation in the entertainment or any other sort of recreational activities, which is very limited for them. It is only in the households. I think that has to change with a better infrastructure for the disabled.
Actually, it's their fundamental right, like it's your and mine. So, I mean, it's not that anybody is doing them a favor by allowing. And I think the infrastructure, we'll have to have the request the government to help for the infrastructure. But for the people's attitude, it is the people who have to understand, you know, it's not the child's fault.
Yes, equal right to enjoy all the facilities.
Absolutely, absolutely. Thank you so much, Dr. Lokesh. Then, you know, we can, you know, just next question, Dr. Mahesh.
So, the next question is, how can the society or general public be sensitized regarding the issues faced by such children and their parents?
For this, we need awareness about these diseases in the society. There is a need to educate most of the public about these common neuromuscular conditions, why they happen, how it happens, and how the child and the family suffers. One good idea would be to make use of this awareness campaigns or awareness week. For example, like in the month of August, we all celebrate SMA Awareness Day and Awareness Week. So similarly, we can do for other diseases also, wherein the general public can be educated about these disorders, the problems faced by the patient and the family, and the public can be educated to be more empathic to this type of parents and the families. By doing this, we can definitely support the families, the parents and the children also. So I think we need to have more such celebration of these awareness weeks, maybe for SMA, DMD, or even for other neuromuscular disorders and other rare diseases. We can have rallies, we can have walkathons on these diseases so that we can educate the public about the different disorders.
Yeah, so we have many parent support groups and all who are helping. That's why we have future webinars on that. But the idea was that we as pediatric neurologists have to also understand these aspects, and we understand, but it should be coming into our back of the mind, and we should think about it while handling these patients. So, for the destigmatization, only we will have to use the media and other sources, which we'll be discussing next week. But the humanistic approach, you know, each life, हर लाइफ की वैल्यू इक्वल है, हर एक का राइट उनको इक्वल है, उनको सेम रिस्पेक्ट, अंडरस्टैंडिंग और एम्पैथी से देखना है, और किसी को किसी के ऊपर, यू नो, यू कांट लुक डाउन अपॉन एनीबॉडी, मतलब उसकी गलती नहीं है, you know. So I think that is very important. So Dr. Mahesh, would you like to say any message for parents based on this ethical issues, destigmatization and humanistic approach? कैसे handle करें with the focus on DMD SMA?
One thing we need to make it sure, make it clear that it's none of their fault. It's not due to anybody's fault that it has happened to them. Okay? And it's just that bad luck that they have a child with this disease. And we need to give the best possible care to the baby. And you should always motivate and congratulate the parents for what care they're doing. Whenever these children, parents come to my OPD, I always motivate them, and I tell them that they're doing a good job and keep their mood high so that they continue to take care of these children. And we need to work with the government also, and to see to that we have appropriate facilities to take care of these children with the disabilities, not just neuromuscular, but even other disabilities also.
Thank you, Dr. Mahesh. Dr. Lokesh, I want to ask you one thing. There is a big ethical dilemma which is happening because, see, we have been talking, you could have seen in the list of webinars, we've been talking about how to diagnose, what are the management options currently. And yesterday we had a holistic multidisciplinary care, one panel, and the other one we had on the myths and the, what are the status of the new drugs, what is the hope versus hype and all. So the issue is, one message is that we need to tell the parents, which we are trying to say, but we like you to tell that holistic multidisciplinary management is important, that they have to fix. And like many people of DMD not taking steroids, one that, and parents are sort of, look, and all the DMD, the genetic defects as of now are not amenable. Only a small proportion are amenable to exon skipping or the nonsense mutation, one bypass for the metalloran. And for the SMA, we have many 3 medications available, out of which only one is DCJ approved. But the basic problem, despite the rare disease policy, which we'll be discussing next week, but there is the issue, ethical issue I'm saying is, parents know, like for others, we say the research is on. The parents know that these are available. So, and there are some humanitarian access programs going on. We'll be talking about that earlier. But then we are putting, see, we are putting it on in the lotteries, like, you know, so I mean, we are putting them lotteries for the for one company which would every 2 weeks, Novartis is taking out lotteries for by on computer only, so that it is you know, it is impartial. But still the parent is waiting, and sometimes, you know, we've had twice their child got selected in the lottery, but the child succumbed just before the medication came. So the parents, what they are going through, the ethics behind that is what I mean. How do you ask them? How do you counsel them for this? Because that's a major thing now, because it's out of that's 16 crore for Zolgensma, and for SMA, that other first year is 4 crore and next year is 2.1 crores, and for Risdiplam is generally around 1.5 crore a year, and for all those trial is 10 crores a year. So they are such beyond that. So that's, don't you think that's an ethical dilemma? For the parent,
it's a huge dilemma. Actually, much before all these things, we had actually got involved in treatment of Pompey's disease in 2009, wherein even at that point of time, this system was there, wherein it costs usually around sort of somewhere between 50 lakhs to 1 crore, depending on the weight of the child, these enzymes. And that was also based on a individual basis. The people used to do meetings and then decide which patient might benefit. But obviously for SMA and the Duchenne muscular dystrophy, the numbers are so high, and parents will feel very bad that, okay, there is a treatment which I'm not able to give to my child because I'm not able to afford. I think first thing is here, nobody is going to be able to afford ever the price tag of anything around 1 crore or more for a treatment. And especially something which is recurring is especially much more challenging. It's not just about whether you are earning that enough. Nobody in the country, even in US, nobody will be able to actually afford that amount of expenses for the drugs. So it has to, I think the parents have to know that the supportive care is one of the things which we are all doing, and to try and reduce the cost of these drugs, because that is not in the hands of either the government at this point of time, because the companies have invested years of their research, and they have invested their billions and billions of dollars to produce these drugs, and they have to recoup this cost. So all those things will be included in the costing in the initial part, and hopefully over a period of time when these things are actually sent across, these medications are available across the world to more number of people, and it can be produced, a mass production can be done when the patenting is there. So then probably we'll have access to more number of drugs at a lower cost, which can be provided to these families. But at this point in time, definitely it's a huge ethical dilemma, and parents have to understand that they are doing their best, and it's not their inability to provide, because nobody can afford to think of paying 16 crores for a drug. And these humanitarian programs are only so limited, they cannot afford to cater to the public in general of so many, the disease with such high incidence of 1 in sort of 25,000 or 6,000, depending on the population you are looking at.
Thank you, Dr. Lokesh. Mahesh, you want to add on? How are you handling telling the parents about these medications, and from your experience?
Yes, ma'am. Most of the time I'll tell parents that this is one of the options, and even if this is not possible, the other treatment like supportive care, physiotherapy, positioning, they are also very important. Okay? And by these measures also, we can keep the child comfortable, and we can improve the quality of life. So if they get through this humanitarian access program, it's well and good. If they don't get it, it's also okay. we can definitely care for these children by other methods. And that's how I counsel the parents. One more thing is important that in most of these newer gene therapies, it's important we pick up the child early. So if you diagnose the case early and if you start treatment early, only then you get good results. If the treatment is started a bit late, then the outcome is not that good in most of these conditions. So that also we need to counsel the parents.
Yeah. And what about the parent support groups there? Like in there, are you involving them for the their the holistically the management and all for the parent support group, so that they help overcome these things, so that the destigmatization and humanistic approach, like they can be helped, because if the two parents are there, they are there. So I don't know, there are some support groups which are there. We'll be having discussions. So we just were wondering how we can do that.
I tend to call patients with DMD and SMA on a particular day in a month, so that they all can get together, and they do feel that they're not alone in the world. So they do feel that it's not they're alone that are suffering. And when they come in a group, they can discuss amongst themselves. They can share their ideas, and that will make them feel more comfortable. So most of the times I call them on a particular day in the OPD, so that they can talk to each other and allay their anxiety. In Belgaum, we don't have a separate parent support group, but it's high time we should start one here.
Yeah, that's thank you, Dr. Mahesh. Thank you, Dr. Rakesh, for joining.
Yeah, thanks. Good afternoon, everybody.
Good afternoon. Rakesh, Dr. Gautam will ask you two questions related to the ethical issues. Please.
So what are the international and national guidelines regarding the ethical issues that need to be addressed in children with chronic neurological disorders like DMD and SMA? And the other question is, what are the ethical and legal issues pertaining to the drug trials for newer drugs in DMD and SMA? And what are the rights of the parents and the children and their parents in such drug trials?
Okay, I think the guidance in terms of ethical issues, I think that's a little bit, let's say, I think we need more clear-cut guidelines on some of these issues. Now, obviously, these are conditions which are progressive, debilitating conditions, and now you have emerging therapies that are coming in, and we wouldn't really know the long-term effects or long-term, course with these drugs as well. So in that kind of a setting, I think the issues would be about humane approach in terms of continued care, good supportive care, irrespective of, these are just general ethical principles which would be applicable to these chronic neurological and neuromuscular diseases as well. And the main things that, let's say, if you have new drug trials and all which are coming, I think it's a good thing, and we as a community and the society should encourage participation of the kids affected by these conditions, their families, to participate in such trials, because only then there's going to be progress and availability of potential cures or even things which could improve the condition and the quality of life. The ethical issues that come in with some of these chronic conditions in a setting of a trial include, one of the key issues is that the trials typically would be of a limited duration, maybe let's say a year or a couple of years or 3 years. The concerns that come up are once the trial is over, those kids who receive the new therapies, those who also started to respond to it, how do you ensure continuation of the these treatments? So that definitely is as an important ethical issue, which I guess the ethics committee do consider. Now, having said that, this is from the, let's say, the family affected kids perspective, that there has to be continuation of care. The other side of the thing is that many of these therapies are likely to be expensive, limited availability, and so on. And in such a setting, how long would any organization or a commercial establishment be able to commit to duration of therapy, that's something that's an issue. A lot of these issues come up when we talk about the oncology treatments, but typically there we are not talking about, continued care for many years. It would be for a shorter duration. So often people do take, stances there. So this is one area which would need to be kept. And I'm sure, with discussions, deliberations, there may be some kind of a guidance as to how one would go ahead and deal with these situations. So these are the main points that we wish to highlight. Obviously, the other basic aspects which revolve around all the ethical issues or clearances would remain the same even in these settings in terms of the process being transparent, the parents and all knowing about it, ensuring, having safeguards to ensure safety. That's something that is critical. And, keeping the rights of the family in mind in terms of their decisions to continue or to withdraw. So all those basic aspects which revolve around any trial would also be applicable. Only issue is about, the provision of the intervention once the so-called trial period is over, particularly in those who responded particularly those who responded well, for example. I think that's something that's is still a gray area, is what I would say.
Yeah. And Rakesh, about the insurance, what I wanted to ask, because we were facing this problem, the parent support groups had come and they wanted some stem cells related trials to be done. And they were funds which we could arrange with Dr. Sujata Mahante and for some patients, But then we got stuck because we have to have insurance, right? So insurance for the trials for something which is not funded by the pharma. The pharma funded, that is inbuilt in their trials. So when it is a proposal coming to ethics committee, so I mean when we're putting and which is not funded commercially, and then we try to actually get certain insurance companies, but nobody came ahead. Then the parents said, we will give in writing that something happens, it's okay, we are responsible. But that was not, that we did not go ahead because we couldn't get insurance. So how do we do for non-commercially funded trials to get insurance for any adverse event, SAE, serious adverse event thing? I mean,
I think I think the ICMR had issued some guidelines around this, the so-called investigator-initiated trials, wherein I guess the insurance part was not mandatory. I think, and we could just have a look at that and look at it clearly that whether particular instance of using stem cell therapy would fall within that ambit or not. And in which case you possibly may not need insurance. Obviously, it has to be understanding and so on. And the steps of approvals and all would still be the same. So in addition to the approvals from the ethics committee, I guess one would also need specific approvals from the committees that monitors various stem cell therapies. And again, I think the ICMR has issued very specific guidelines for research in the stem cell therapy as well. So these are the aspects that one would have to look at. So one obviously would be the scientific merit, and the way you're going to do it means obviously many times, and we have seen kind of reports coming in where practitioners or these organizations which are harvesting stem cells from the child himself, herself, and trying to use that for therapy in conditions which are clearly genetic. And that doesn't seem to make sense, but there are a whole lot of these practices that are going around. But obviously, I think that's why I said that, the scientific merit would be the plausibility would be the first thing. And I think if it's an investigator-initiated one, then possibly one may not need. But I think I would urge to specifically refer to the ICMR guidelines for a definitive word on this particular one.
Thanks. And Rakesh, what is the status of taking ethical approval for certain therapies which are not approved as of now? But if the parents approach to us and they say, and there is some evidence to it, and as a kind of a rescue thing, I mean, where do we stand right now? Whether we, for individual case-to-case basis with evidence, like is that entertained or it's not? Why I'm saying is because पेरेंट्स सुन रहे हैं, वो आते हैं हम लोगों के पास कि वो आप कराइए, तो फिर इसलिए दे शुड ऑल्सो अंडरस्टैंड कि वो है, बिकॉज स्टेम सेल्स जो गाइडलाइंस थी जो ICMR व्हाट यू आर मेंशनिंग, आई एम पार्ट ऑफ दैट, तो आई अंडरस्टैंड अबाउट स्टेम सेल, वी डिस्कस, द ओनली थिंग इज पेरेंट्स कई बार आके दे बिकॉज वी हैव बीन डिस्कसिंग कि दे आर ऑल्सो हेल्पलेस, राइट, बट दे कम एंड आस्क अस, तो इसीलिए वो है कि what where do we stand, मतलब something which is not approved but can be
so I think what I get it, so this would come under the ambit of so-called off-label use of therapy, right? That's what it is.
Yeah.
And if you look at it, particularly in the pediatric setting, a lot of our practice is actually off-label. You really don't have evidence to support even the most basic of the things that we do, but over a period of time, we know that these things work and they are safe and so on. So typically, one doesn't really go ahead with the ethical approvals for off-label use of drugs or therapies. And I think it would vary from ethics committee to committee whether they entertain these kind of proposals. I think from what I understand, and we really haven't had too many instances as such of people approaching for specific therapy for a particular case, which is not really part of a research trial. So if it's coming as a research trial, yes, it has to go to the ethics committee for approval. But if you're looking at an individual case, then possibly, one doesn't need to go to the ethics committee. If let's say you think that there are many people are going to approach you for something which is based on stem cells and so on, and the team puts together a proposal to scientifically look at the outcomes and so on, and as a prospective study, then definitely it has to go through the ethics committee. But I think the individual patient off-label usage would be within the domain of the treating team and their call as to how they're going to be doing it. Something that is means I understand the team would also be more comfortable if, let's say, another group vetted what they intend to do. But I think most of the time the ethics committee may not be getting into individual patient treatment related decisions, unless it's really part of a research study.
Thank you, Rakesh. Because
I guess the team would definitely look at all the pros and cons in terms of the safety, particularly of whatever intervention is being planned, and it has to be coming in. But again, I would just emphasize that even in conditions where let's say there's no therapy available, and one would still need, as practitioners of modern medicine, one would still need some bit of some clue or some even slightest of evidence or some biological plausibility before one went ahead with trying something out. From the perspective of a family, it's okay for them to say in general that let's try. If a person ABC told them that, look, stem cell therapy worked or a particular indigenous medicine worked, whether we are going to use it, I think that would be based on our understanding and rather than empirically doing it. So I think my suggestion would be that it has to be approached from a scientific basis. We understand that the parents are in a situation, they are in a spot, and therefore they're willing to try anything and everything which anybody may have said. But I think there should be a more scientific way to approach this rather than just based on a parent request ki karke dekh lete hain. I think we don't do that. And even in our other treatment decisions, we always go through that process of evaluating that therapy, the pros and cons, and only then we're going to do it. And not just that, that it may work and therefore let's give it a try. No, I don't think so. That should be I'm sure that would be the approach for all of us. We all would be taking similar stances.
Absolutely, Rakesh, because wo puchte hai, so I thought it should be heard from you bilkul clearly, taki they are not thinking about it, because hope is one side, but hope doesn't bypass the scientific rigor in the thing, because even stem cell can have a lot of cons, मतलब advantage hai. It is something about the future, but it is not a magic thing right now. वो like what you were saying कि अपने बच्चे का genetic बीमारी है उसको डाल दिया, which doesn't make any scientific sense until unless somebody is doing a genome editing. वो तो हो नहीं रही है है ना. तो मतलब that is why, so that things is wrong, so which we are trying to understand, but these are very important questions which parents ask. तो इसीलिए we ask because we are catering to patients and all. And abhi I will request Dr. Kakuli to take the questions of the session, and you can please see on the YouTube link also if any questions are posted there. And then we'll just post the questions to three of you. Right now, Dr. Vishal Sundi had signed off, Dr. Mahesh Kamate and Dr. Lokesh Lingappa there, and Dr. Rakesh Lodha. And we can put the poll also simultaneously. Should we put the poll also?
Yes, sir. Thank you all the panelists and the participants who are there. We'll start with the polls also, and meanwhile we'll take the questions also. There are a few questions which needs to be addressed, and the poll would be active for 3 to 4 minutes. The first question which we have is social isolation, especially as there is no wheelchair accessible transport available to take them out at all, and they are confined within the 4 walls of the home. I think the
yeah, it was given. Yeah, but Dr. Lokesh, you want to add something? Dr. Lokesh?
Yeah, sorry, I missed that, Dr. Shefali.
No, I understand. You are also in the OPD. I'm really grateful in the peak times. Can you repeat the question? Yes. They're saying that the child is indoors, mostly indoors, so there is a social isolation. Yesterday, we did discuss about the holistic care and talking about all the endocrine things and all the vitamin D and everything, but the social part, because you remember we were talking about the social aspects and but how to handle that.
And also, prior questions, the panelists have already addressed that there is no wheelchair accessible transport available in the common areas.
Yeah, Dr. Lokesh, want to add how we can?
Yeah. So I think that's what I think, as we discussed on a larger scale, if we have the limitations of accessibility is taken out of the mind of these children and the families, that yes, I can go anywhere with my device or with the difficulties, I can travel around, move around. I have accessibility everywhere. So that actually takes out the fear of these families to move around and have the sociability. And also acceptance from the families, the society as such in general, that yes, they are part of the society. These are variations of nature that nobody has any control on, and they have to be accepted as part of the society. I think these two are the major challenges which we have to positively work to overcome. I think it is not possible on individual basis or just by doctors. It's the society and the government has to have its agenda to help these people to be integrated as to part of the society. But short term, I think in effort by the family and the local communities to make sure there is some activities planned with these children in mind would actually help, and the support systems, the social support groups, the disease support groups actually can help these things to happen in the local areas. To have a area community hall, the marriages happen, the other functions happen. Why can't we have a day in a month fixed for these kind of activities? These children go out, mingle with other people, have without any fear of problems with the accessibility and other things. I think those things should be organized.
Thank you, Dr. Lokesh.
Thank you, Dr. Lokesh. We have one more question where the caregiver and the parent is saying, if we are not taking steroids, the allopathy doctor is not willing to see our child.
Dr. Mahesh?
What is the question, ma'am?
They are saying कि steroid नहीं लिया तो allopathy doctor बच्चे को देखने को तैयार नहीं है. They are saying कि if we are not taking steroids, then the allopathy doctor is not willing to, the child.
We've been talking in the last, last 6 webinars, we've been talking about the holistic care and the steroids people have not been taking, and that has to be taken. So they're saying that the steroids are not being taken, Mahesh, then the allopathic doctor is refusing to see the patient. I don't think anybody can do that, but
it is one of the treatment options for DMD. And there is currently good evidence to say that steroids do help in this condition. So once if we can convince the parents about the effect of steroids, and if we can tell them that we can monitor these children for side effects, maybe the parents can get convinced to start steroids. But if they wish not to start steroids, we should continue to give supportive care to this family.
Yeah, so what the parents probably has written, ki their allopathic doctor has refused. I don't think anybody can refuse seeing a patient. Yeah. Just that, so we have to just emphasize. And if you had not attended the second webinar in which we talked about the recent advances, तो आप देख लीजिए, because वो सारा YouTube में है, तो उसके अंदर पूरा डिस्कस किया और बार बार बोला जा रहा है कि स्टेरॉइड्स का ऐसे ही नहीं दे रहे हैं, उसका साइंटिफिक एविडेंस है, इसलिए दे रहे हैं. That is yeah. Thank you, Manish.
We have a next question. The parent and the caregiver is saying, can the social worker act as a chain between the parent and the doctors, where the systems can be educational and can help the patient?
Dr. Lokesh? Or Dr. Mahesh, anybody?
Definitely, ma'am. So the social worker can definitely take up that role, because in our country, most pediatrician trainers are quite busy. So if they don't have the time, the social worker can definitely take up that task, ma'am, in educating the parents about the disease also, plus in providing support services, both financial and other way also. So the social worker definitely can play a very important role in treating children with neuromuscular disorders.
But I have a question, Dr. Mahesh.
Yes.
Where are the social workers? I mean, do we have? Because I think we have only one social worker in pediatrics.
I know.
And how do we have so many super specialities? So I don't know. So, I mean, they can act, but where are they? That,
whenever they're there, they definitely can have a great help. Yeah.
Dr. Rakesh, how can we get such, because there's a n number of things only, which we as specialist clinicians can do. So how do you suggest that we go ahead and have this cadre of social workers? Like we have in the department, we have specific nurses, like you have intensive care nurses, you have neurology, nephrology, all of them have specific nurses who are training. But if we have this social worker thing, how can we inculcate? I don't know. I just don't. Any thoughts, Dr. Rakesh?
I think this is a challenge. I think, and I guess one, I would think that one needs a more holistic view. The issue is that while we are, as a country, or even in a smaller scale as an institute or a clinic, we may be doing, looking at some of these more chronic or more debilitating diseases. At the same time, we know that our resource allocation and utilization for more acute, more life-threatening, immediate kind of things are also, are not adequate. Now, in such a scenario, one would have to take a more holistic view and have a balance of things from, the system's perspective, so that only then it would work. If one has to run, let's say, a specialty clinic or a service for a certain set of disorders or rare diseases, then obviously to expect that the institutions or, the public health funding is going to come in only for that is going to be a little bit difficult, because our policymaker is obviously going to look at the numbers on different disease conditions or various conditions, and accordingly the resource allocation may happen. However, there would be scope for help groups and all to come and, do pitch in for these kind of things, because to expect that the state or the public health system is going to be able to provide for these things at a time when we still struggle with, I would say, other pressing and, in terms of the burden of diseases, so many other things that we face. It may not be feasible. It's certainly absolutely okay to pitch for these additional healthcare professionals or healthcare workers and social workers, but from practical perspective, this is unlikely to cut ice up or get something from the policymakers. So till that happens, and it may be a long period of time, I think the self-help groups, the civil society, and other people could start chipping in certain ways. And there are various, I think these bodies are in place for various disease conditions. There are particularly chronic diseases which may not be too debilitating. The individuals who are affected do work as volunteers and spend some time and try and sort these out. I guess that would be the way forward that I look at. The other issue is that a lot of it has to be a team effort. So just as you mentioned that we have a respiratory nurse, and for conditions like, again, rare diseases like cystic fibrosis, we have involvement of the nurse, we have involvement of the nutritionist, the physiotherapist, and so on. So it has to be a team approach. It may be feasible in some of the tertiary institutions, but when we really get down to maybe the secondary level and all, which would be a more resource constraint, I think one would still have to look at some of the innovative options and some bit of task shifting, and also some bit of involvement from volunteers or these parents' bodies or trusts that are formed, who could be doing offloading some of this from both the specialists and as well as support the families.
Thank you, Dr. Rakesh.
We have one more question from a parent. If a DMD child who now has no learning disability in the childhood later can have progression in cognitive and learning issues?
Dr. Rakesh?
Yes, ma'am.
Dr. Lokesh, they are asking about a child who is cognitively preserved, a DMD, later on can have some learning issues?
The learning issues are noted from the beginning itself. They generally don't have it later on. So they will have intellectual delays. Very small percentage of them are known to have increased incidence of autistic spectrum disorder as well. But that might come into fore later on, because as the challenges in the school increases, they are in the first standard, a child might be able to cope with the level of challenge in the school. But in a fifth standard, the same child with the lower cognitive levels may not be able to cope the fifth standard topics. So that might be apparent at that time, but the cognitive challenges are there from the beginning. So that's why if you do an IQ assessment, whenever there is a initial part only, we'll be able to pick them up and support them in the school.
Thank you, sir. We have one more question. What are the ethical issues of euthanasia sought by adult patient at the end stage of DMD?
Dr. Rakesh?
Yeah, I think I wouldn't really want to get into this aspect. I guess one would have to go by the law of the land, and I think that's about it. I think we just need to keep this in mind that people do talk about euthanasia and in chronic conditions, incurable conditions, and so on. But I think there could be a big debate, and but I think one would just stick to the law of the land, which doesn't permit the same.
Yeah, the message उनको clear है कि legally allowed नहीं है, right?
Obviously, one would, when we talk about ethics, when we talk about legal, we are talking about frameworks, right? Even if, let's say, one may think, and if there's certain countries which allow for it, one cannot really, I don't see any reason to even debate about these things of something which is clearly considered illegal at this time point.
Yeah, so but the message is still has to go. Yeah. The message is illegal. That's it.
That's
right?
it. Yeah, that's what I would think. Yeah.
Yeah. We have to be very clear, Dr. Rakesh. You're absolutely right. We have to abide by the laws and all. We can't have our own decisions. They are based on the guidelines and the laws, right?
Yeah, I mean, this is there. While I think we do, the family's perspective and other perspective, one does keep that in mind. But at the same time, I guess it's the overall framework or the rules or the laws that have to be respected. There's no way that you could, override those. I think that be clear. I think unless there's a change in that, I don't think we should really be as professionals getting into a debate at least on this kind of a platform, right?
Absolutely. Thank you.
Thank you, Dr. Rakesh. We have one more question and a suggestion also in the same question. Is there any restriction, regulation by government on collecting data of number of patients for any medical condition? And the suggestion is, can any NGO do it, or does it need to be authorized by medical or government bodies?
See, when you are going to collect any data, Rakesh, we have to take consent from them, right? You want to, and right, we
I
have
don't know, maybe.
ICMR.
So I think what they would simply maybe just, so one simple thing could be that one is interested in knowing the burden of the condition, which means that how many kids across the country have a particular condition. Now, that's just one set of data. Now, obviously, the best way to do it is in form of a structured approach to, as a registry. That's what is going to really get you the details. Apart from that, the people do seek such information with the Right to Information Act and under the provisions, and they do try and pull it. But again, I think the purpose may not be served for a very simple reason that for many of these conditions, you will be able to approach only a certain set of institutions. And that would give you only a bit of a view of what is the number, right? It doesn't really serve the purpose. So if one is really interested in kind of having detailed, then I think the effort should be to develop a registry. And I think the government is taking initiatives, or, the Rare Diseases Initiative and that kind of a thing, which is going to happen. And it may take some time, but I think that's a better way, a centralized way to collect data. And not just the numbers, then you're obviously collecting other information which may be meaningful in, let's say, setting up a trial, right? As to what sites may be good sites for doing that study fast enough. So those are things that one has to keep in mind, and that's what I would suggest. People could always go and ask for information, but again, how the authenticity of that data, how one interprets it, and the completeness are obviously going to be questionable. So it has to be, if it's to be done, it should be done properly. That's what I would think.
Absolutely. And what I'll add on, जैसे जो डॉक्टर राकेश बता रहे हैं कि सपोर्ट ग्रुप, एक सपोर्ट ग्रुप कोई बीमारी का था, नाम नहीं ले रही हूँ, उनके पास हमारे पास कोई ट्रायल आना था, तो उनसे बात किया, तो उन्होंने कहा वी आर वेरी इंटरेस्टेड फॉर दैट ट्रायल. फिर जब वो ट्रायल आया, तब उनके पेरेंट्स को जब देखा, तो 2/3 पेशेंट को तो वो बीमारी थी, लेकिन 1/3 पेशेंट जो थे उनको वो बीमारी नहीं थी जो उनके डेटाबेस में थे. तो डॉक्टर राकेश कह रहे हैं कि प्रॉपरली करेक्ट करना. वैसे ही आईसीएमआर की रजिस्ट्री है जो रेयर डिजीज के है, और जिसमें न्यूरोमसल डिजीज का भी है, जिसके अंदर अभी हम 3 डिजीजेस कर रहे हैं, जिसमें डीएमडी, एसएमए और एलजीएमडी है. और डीएमडी और एसएमए पे ही हमारे ये वेबिनार्स फोकस्ड हैं बेसिकली. तो वो उसमें आईसीएमआर रजिस्ट्री में हो रहा है. उसमें कुछ प्रॉब्लम हुई थी उनके सॉफ्टवेयर में, तो वो जरा रिफर्बिश हो रहा है. तो डेटा कलेक्ट सारे साइट्स कर रहे हैं अभी वो भी मेजर इंस्टीट्यूट में साइट था, लेकिन अभी वही बात करें ना कि कहाँ तक रीच करें. तो उन्होंने बोला कि वो मेजर जो एरियाज हैं वो भी अपने ड्रेनिंग एरियाज को बढ़ाएं. तो बेसिकली अभी चालू हुआ है मेजर हॉस्पिटल्स, फिर वो उन सिटीज के ड्रेनिंग के अंदर प्लानिंग कर रहे हैं कि ताकि रीच आउट करके जेन्युइन डेटाबेस बने कि इतना एन है, ताकि गवर्नमेंट को भी पता है कि हमें इतने रिसोर्सेज चाहिए. प्लस जैसे डॉक्टर राकेश ने बोला कि ट्रायल्स के लिए कौन से पेशेंट कहाँ पे है ताकि वो हो जाए. सो उसके लिए वो आईसीएमआर रजिस्ट्री है. और मीनवाइल हमारे सेंटर ऑफ एक्सीलेंस एंड एडवांस्ड रिसर्च न्यूरो डेवलपमेंटल डिसऑर्डर्स का है हमारे चाइल्ड न्यूरोलॉजी डिवीजन डिपार्टमेंट ऑफ पीडियाट्रिक्स में, जो मिनिस्ट्री ऑफ हेल्थ और IFCL से फंडेड है. तो उसमें भी एक रजिस्ट्री बन रही है, जिसमें एक कंसोलिडेटेड रजिस्ट्री बन रही है, जिसमें उसमें चाइल्डहुड न्यूरोलॉजिकल और न्यूरो डेवलपमेंटल डिसऑर्डर्स की एक कंसोलिडेटेड रजिस्ट्री है, विच ऑल्सो हैज फॉलो अप. तो वो एक अभी हम शुरू कर रहे हैं, which is in collaboration with Ghosh and CMC Vellore. तो उसके बाद अभी वो उसका शुरू होगा, तो अल्टीमेटली हमारा डेटाबेस बढ़ता जाएगा. पर ये रेयर डिजीज का आईसीएमआर वाला है, जिसमें वो currently it is in place. Any other question?
The same parent had also asked if any parent advocacy group can take authority with consent letter of data collection.
Yeah, even data collection in ICMR registry is with due consent. We have to have a consent taken for that. That is there. I thank you all. I would request Dr. Mahesh for any message, final message.
My message would be like there need to be more awareness about these disorders in the community, ma'am. And even we need to talk to the government also, so that proper facilities can be provided to for these children, especially for their mobility and for their recreational activities, and even some message to the schools also, so that they can accommodate these children in school and they can help in education of these children.
Yeah, thank you. Dr. Rakesh?
Yeah, no, I think yeah, concerted effort is required apart from, so the holistic care and the so-called non-pharmacological aspects of care, which Dr. Mahesh has also highlighted to just improve the quality of life. Those are important. From the perspective of research, I think research is something that should be, encouraged. Within the, that consideration, I think people often get averse to the word research. But then when we are dealing with difficult conditions like these, it's important that one has to, look at research from a very positive frame of mind and not shun it. That's something critical, which means only then we are likely to have new therapies. There are multiple examples where the affected individuals have, contributed to research or have encouraged research or even collected funds for research in a condition. And the fruits of that would be seen after a period of time. It's nothing like, if you put in money today and you're going to get a result tomorrow. But it's not just about money, it's also about the commitment and involvement. So that's where I guess the parents or the groups could be helping. The framework for research would be, would have to, whatever is the legal framework or the regulatory requirements would have to be complied with whenever one is looking at studies. And the ethics committee's roles are predominantly to look at the safety of the participating individuals. And there would be other requirements which would be, which would have to be met to make sure that these requirements are met. And at the same time, the idea of the ethics committees and all is to facilitate research, but keeping the safety of the patients in mind. So one should have a very, let's say, one should be involved in research, and this would clearly need partnership with the affected children's families and their support. Only then these two could be taken further. Thank you.
Thank you, Dr. Rakesh. I think Dr. Lokesh अभी logged out हो गया, उनका अपना OPD में थे. So I'll hand over to Dr. Kakuli for the housekeeping. Yeah.
Thank you all the panelists and the participants who had joined and made the session successful. Definitely regarding the ethics, it requires experiences of the families who are acquainted with the disease. Therefore, the ethical expertise needs to be organized not only interdisciplinary, but also includes experimental knowledge through the inclusion of patient representatives. In the coming other webinars, we will be definitely supporting with the sessions, which will cover up on the prohibitive cost, parent support group for the panel for SMA and DMD, will cover up the role of pharma industry, role of NGOs, rest of the world and India, national, both the things will be covered. And the main thing which will be covered is the crowdfunding, hope or hype, and also the financial solutions, humanitarian access program, which we are running at our center, and the financial solutions which can be benefited through employee beneficiary schemes. So, हमारे साथ बने रहिए आगे के सेशंस के लिए. Over to Dr. Shifali.
One thing, next week next week हमारा जो सेशन है उसके अंदर बेसिकली नीड फॉर रिसर्च बहुत इंपॉर्टेंट है कि जो इतनी एक्सपेंसिव मेडिकेशन से यहाँ हो, डॉक्टर खादिलकर विल बी लीडिंग दैट, एंड गवर्नमेंट ऑफ इंडिया की रेयर डिजीज पॉलिसी जिसमें डॉक्टर आईसी वर्मा, डॉक्टर मधुलिका और मिनिस्ट्री से लोग होंगे जो बताएंगे. बाकी आपको डिटेल्स आपको डॉक्टर काकुली ने बाकी को बता दिया है. और उसके बाद जो 25 तारीख का है एक बहुत इंपॉर्टेंट टॉक है टू अंडरस्टैंड कि कैसे हमें चैलेंज जो कॉस्ट का है करना है, विद मेडिकल इंश्योरेंस का क्या रोल है, और पेरेंट सपोर्ट ग्रुप. और लास्ट में हमने सबसे आखिर में जो 20th है वो पेरेंट काउंसलिंग और कोपिंग स्ट्रैटेजीज रखा है. इन बीच में सेल्फ एडवोकेसी वगैरह भी और प्रिंट मीडिया एंड ऑल सबका. तो होलिस्टिकली ओवरऑल क्या इम्पैक्ट आ सकता है लाइफ में ताकि आपकी जो फाइनेंशियल एडवोकेसी की तरफ चले जाएं. Thank you so much. And ये सारे के सारे जो हैं वो YouTube में है, and they will be there in AIIMS website. It will be in our www.pedneuroaims.org website. Global Genes का USA उनका website में all of them will be streamed. Thank you very much. All those who are
Next
participating.
session हमारा 24th August को है अभी.
10 o'clock. All the sessions start from 10 to 11:15 and 11:15 to 12:30. Thank you, Dr. Rakesh. Thank you, Dr. Mahesh, and all those who have joined online here and on the YouTube.
Okay, thank you. Thank you.
Thank you. Thank you.
Thanks.